Hi, today I'd like to share a small case about community-acquired pneumonia and its relationship with ventricular tachycardia. And it's like so. I usually like to start with a case. We have a case here, a 78 years old male admitted to the hospital with community-acquired pneumonia, CAP, for 2 days. And during his time in the hospital, he complained to have palpitation and nausea, which he denied lightheaded and chest pain. His pulse came up to be 62 beats per minute. His blood pressures to be 113 and 65, and there's no anomalies in his physical examinations. His sputum cultures came up positive for mycoplasma pneumoniae. His basic metabolic panel shows no abnormalities, which means his potassium levels, his magnesium, calcium, sodium, and others, they all in the normal range. And we have his ECG here, and here we can see the pattern of this ECG. You can see this they are not regular, so we call it polymorphic. Poly means many, and morphic means how it looks. So we have multiple different looks on this ECG. That's how we name it, polymorphic. And obviously this is a ventricular tachycardia, and we add up these keywords together, polymorphic ventricular tachycardia, which means we have Torsade the pointe, which is a very, very critical situation. So what you're gonna do is consider this patient is in hemodynamically stable. We have to give him intravenous magnesium sulfate immediately, and also we have to identify the cause of his QT prolongations, which, as we know, one of the cause of the Torsade point is the progressions of the non-QT syndrome. So we have to treat the underlying QT prolongations to treat these patients. And why, firstly, you have to think about why he got this non-QT syndrome. And we have to take a look at the history here. This is a very important point, because if you think about the antibiotics given for the mycoplasma pneumoniae, that is macrolide. So this antibiotics is well known to be one of the cause of prolonged QT, so you have to replace these antibiotics into doxycycline. So although this patient he is hemodynamically stable, but I'd like to talk about what if he is unstable. If he's unstable, then you have to give him immediate defibrillations and CPR until his vital signs stable again. Then you can move on for the pharmacological antiarrhythmic treatment. And after you treat this patient, still you have to consider of his long-term management. So you probably give him a beta blocker therapy. If his QT prolongation is still happening despite his beta blockers, it means he's probably in a high risk of another persistent sustained ventricular tachycardia. You have to consider give him a AICD. So this is the ultimate option. But also you have to treat any underlying congenital QT syndrome. You have to look for other causes if you still can't, if other things cannot treat the patient completely. And I would also like to have a small list about what those acquired long QT syndrome are, because as this patient, his cause obviously from antibiotics, I would like to mention other causes. So we have a list of antibiotics here and also here. So these are all common antibiotics we're going to use. This is antifungal, by the way, so have to be aware. And then even though there's some antiarrhythmic drugs, they are antiarrhythmic as the name called, but still they can be pro-arrhythmic and also causing long kidney syndrome. So you have to be aware of class 1A and class 3 drugs. And although we know milvexian is commonly used for treating many of the ventricular tachycardia or others like SVT, it's still, sometimes it's still pro-arrhythmic, but still, although it's in the list, but it's relatively uncommonly causing Torsade points compared to other class 3 antiarrhythmics. And also other drugs such as antipsychotic drugs, antiemetic drugs, and despite the drugs, that's why I mentioned this patient. He got his BMD came up to be no abnormalities, so so we don't have to correct his level, but still you have to aware of hypokinemia, hypomagnesemia, and hypocalcemia may cause non-kidney syndrome and worsen to be ventricular tachycardia and ultimately causing Torsade points, which is lethal, which is really dangerous, and also endocrine disorder, and then acute CNS needs such as ischemia, stroke, intracranial hemorrhage. As I would like to make a circle here, make a point here, because I like to remind everyone this one is a common cause of long QT syndrome, and so when you encounter a patient with stroke or intracranial hemorrhage, make sure you look very, very carefully on his or her ECG to check any problem. And yep, this is a small reference of my today PowerPoint. As usual, thank you so much for the sponsor of GE Engineering. And this is the end of my case sharing. Thank you so much.